Welcome, everybody. I am so glad that you're here. BrainLinks is happy to have you join us for this brain injury and co-occurring challenges. We're going to give you lots of information and strategies. First, I want to tell you who we are. So BrainLinks is a grant-based program. We receive funding federally from the ACL, the Administration for Community Living, and we also receive funding from the Tennessee Department of Traumatic Brain Injury Program. So what we're going to do is talk about first, what is brain injury? We're going to do that quickly. The importance of identifying brain injury wherever you are, the overlap with other systems, screening and accommodations for non-brain injury programs, referral options and resources. So what I'm really hoping to do is, if you do not work in brain injury, to let you know that you do see people with brain injury, help you to understand how important that is to screen and identify those people, and then give you some simple ways of working with them within your system so that they are more successful. We have a number of people here who are coming from the brain injury world. I'm always thrilled to have you. And for you all, I want you to listen to kind of like two things. One is how much our people with brain injury get into other systems and how much of those systems we make up. And then also to be kind of thinking about the idea that we need to. I worked in a hospital system. I'm a speech language pathologist. I worked in brain injury for 20 years. So my background is very clinical. And I guess we always kind of had this thought of, oh, we've done such a great job and we got to see them a lot longer than now, that they're just going to go on and they're going to have a great life. Well, now coming into this role, you realize, and as there's been more research in the field, you realize that no, they go on to they can have lots of difficulties. So what can we do to be building in monitoring for these folks, to be warning them, to be giving them some tools, to some things to reference back to say, hey, I'm having a little bit of a problem. What do I do now? Right away. So be listening for those kinds of things. I saw somebody had a hand up. What we're going to do is put questions in the Q&A, and if you just go over to more, the three dots, for me, it's on the right-hand side of that bar. Click on more, and you will look down and you'll see Q&A. So questions, go in the Q&A. Jen will be able to find them better. Jennifer Raymond is here, and also Paula Denslow, our program director. And she'll be looking for them there. And then in the chat, you can just comments or anything like that you like. So what is brain injury? Well, it is, I'm going to hide this bar for me. Put it down here. So there are different types of brain injury. You can have a brain injury at birth, which is called congenital. You can have an acquired brain injury, or an ABI. And then there are different types of acquired. It's kind of like the umbrella. And probably what most people think about is traumatic brain injury. We also have non-traumatic brain injuries, and we also have degenerative brain injuries. We don't generally think of it like that, but it is brain injury. It's brain change for sure. So concussion is one type of traumatic brain injury, and a traumatic brain injury is a bump, blow, or jolt to the head or body, or something penetrating like a gunshot wound. They can be caused by lots of different things, falls and car accidents. I guess here in Tennessee, they're called wrecks, violence, abusive head trauma. We see it a lot in children, sports injuries, and blast injuries. And a concussion is a special type of traumatic brain injury. It is a mild traumatic brain injury, and it is a functional injury versus a structural one. So a structural one would be more where you can look at a scan and you can see where the brain has shifted. You're not going to see anything like that in a concussion. It's a chemical cascade that messes with a lot of our could be our balance, it could be our thinking, it could be just our general sort of uh, the way that we feel. So you're not going to see that on a CT scan. If they're doing a CT scan, they're looking for whether there was any bigger damage or not. But we still hear doctors saying, or people saying that their doctor said, I don't have a concussion because the CT scan or the CAT scan was clear. Well, that won't show you whether you have a concussion or not, at least not yet. Non-traumatic injuries include things like stroke, brain tumor, meningitis, encephalitis, seizures, anoxia, which is a loss of oxygen to the brain that can come with a strangulation, a drug overdose, and near drowning. But we can also see brain injuries coming from metabolic disorders, neurotoxic poisoning, things like carbon monoxide poisoning. So and then of course degenerative um, is dementia. And so what I want you to be thinking about, I would invite you to think about, is expanding the definition that you may be using of brain injury to include all of these things. So when you're looking for brain injury with someone, to be thinking of it could be any of these things. Let's take a look at Zach. Zach is a really common type of person that we would see and family that we would deal with. He was 4 years old when he had an ATV accident and a loss of consciousness. His initial GCS or Glasgow Coma Scale was an 8, which is not great. He's agitated, he's nonverbal, but he's moving his extremities. He has multiple skull and facial fractures. His brain has shifted to the left, which means that there's fluid in there that's pushing the brain to the side. And if left like that, it can cause significant injury. So again, this is a significant injury. It's not a concussion. And by all reports, he recovered beautifully. He looked great. And if you could have seen him in the hospital, he was black and blue. He was hardly recognizable. There were tubes coming out everywhere. And within days, he started to look great. You know, bruising is resolving and all of that, but he seems back. By 5 years old, which wasn't even a full year later, he's in kindergarten and he's failing kindergarten. And this is October. So if you're failing kindergarten, that's bad. If you're failing kindergarten by October, that's really bad. He's hitting other children. He's wandering around the classroom. He's disruptive, impulsive. He's not identified as having had a TBI, even though he came from a small community and everyone knew about the injury. Everyone knew about the accident, but it never really made it into the school. And they're there, but no one's thinking about it. And I met with the teacher. The family reached out to us, and I met with the teacher, and she said 3 times to me as I'm trying to reinforce that we need to consider the brain injury. She said, he's just a boy being a boy. And she was like, you know what, we'll get over it kind of thing. And I can work with this. I worked with it before. Just a boy being a boy. And at that point, I pulled up the hospital pictures and I said, Zach had a major injury. And these are all things that we tend to see after an injury. And you could see on her face at that moment, she got it. And she said, what do I need to do? She was a very good teacher. She had been around for a long time, but even so, it's, we're not used to looking for brain injury. And when we do see it, we don't recognize it for what it is because it can look like a lot of other things. It can just look like that overactive boy, but we need to get on it right away and be giving him some strategies. Let's go on. Nathan is also really common for us to see. So Nathan he's 24 years old. So we're at the other opposite end. But when he was 2, he fell down the stairs. But again, he seemed to recover from a pretty scary concussion. It looked like, oh my gosh, what has happened here? And everyone soon forgot about the injury. He goes on, he's looking good. And by the time he's in 2nd grade, he's getting into fights. He's having difficulty paying attention. He's falling behind his peers. And in his teens, now he's involved with drugs and alcohol. He's falling behind in school and getting into trouble. And by 24, he's been arrested twice. He's had issues with substance abuse and keeping a job. He's experienced depression. He's attempted suicide, and he would be homeless if his mom didn't let him live at home. He was involved in multiple systems of care, or could have been. Some he did touch, some he might get there if he hadn't had the support of his family. But none of those systems knew about his concussion. No one is thinking about it anymore. So even with just a concussion, what we hear is you can have lifelong consequences. So if we had helped people to understand the possible downstream effects of his brain injury, we might have been able to prevent some of the difficulties and helped him, his family, and the professionals along the way. And that the circles just show you kind of how these other systems become connected with brain injury. And then, of course, the schools too. It would have been great if we could have gotten into the schools and educated them about Nathan. Let's take a look at Aaliyah, though. Aaliyah was in a domestic violence situation. She was strangled multiple times. And then you folks who are in domestic violence who are here, you can validate or not that what they often hear is that they were hit in the head too many times to count. It's not just the one, but it's many times. She's trying to get her on her feet in a shelter. She misses appointments, difficulty following the rules. She can't tolerate noise, and she sometimes sleeps on the streets. So that's Aaliyah. Let's give you another example. JJ, he had a concussion during football practice. His grades were dropping in school after that. He had impulsiveness, low frustration tolerance. He was getting into fights. He was arrested over the most recent weekend, and he was buying drugs. And our substance use folks might be able to validate this to make his head feel normal. We hear that a lot, and that's sometimes why we think that we see people going from one drug to another. It's like, okay, that one didn't work. That's not what I'm looking for. Let me try another one. And sometimes at least early on, it can be trying to just quiet something in the brain or activate something in the brain, because it all comes down to the brain. John had high ACE score. So an ACE is an adverse childhood experience. And if the score is high enough, it can impact your brain. It can change the way your brain functions. And he had a brain injury in 8th grade from PE class. ACEs also make it more likely that you will have a subsequent brain injury because of impulsiveness and lack of judgment. He started stealing from local stores. He was sent to a juvenile detention center where he sustained another injury. And we hear that from our juvenile folks that often happens. He fell in with a bad crowd. He started stealing cars, and he was incarcerated twice. So I want to show you this video. It's 5 minutes, but hopefully it'll be better than me talking and showing you the overlap with brain injury. So you're going to see your system represented, most likely. Some of you are coming from broad groups where you work with lots of different types of people, but you'll see different systems represented. But I also want you to see, again, that brain injury is likely bigger than you think, and that it impacts all of these different systems. So let's go ahead and do that. And unless you come on, Jen, and tell me you can't hear it, I'm going to assume all is well.
Yes. Brain injury is bigger than you think. Brain injury is everywhere. It's part of our lives, whether we realize it or not. Can you believe that 1 in 5 people in the United States are living with a brain injury? For perspective, that's like the populations of California, Pennsylvania, and Florida combined. Brain injury affects people of all ages, from infants to teens, adults, and older adults. There are many different types of brain injuries. Most people think about traumatic brain injuries like falls and car accidents, but tumors and strokes can cause brain injury too. Some toxic substances like lead can damage the brain, so can a lack of oxygen from an overdose or near drowning. Brain infections and seizures can also cause brain injuries. Brain injuries everywhere. It has far-reaching consequences for families, communities, and society as a whole. Its impact reverberates in every major system. Did you know that 50% of people in our mental health system have a prior history of brain injury? Substance use treatment centers also have 50%. In fact, in centers that treat both mental health and substance use, 80% have a prior history of brain injury. In the adult criminal justice system, can you believe the number is 87%? For detained youth in the juvenile justice system, it's as high as 67%. Over 50% of people who are homeless or in an insecure living situation have had a traumatic brain injury. As many as 20 million women each year could have a TBI caused by domestic violence. One of the leading causes of physical abuse deaths in children under 5 in the U.S. is abuse of head trauma. About 60% of all people with TBI develop chronic pain. It's everywhere. It's a part of every major system that we as a society struggle with. Maybe you've already heard about ACEs, adverse childhood experiences. Did you know they can also overlap with brain injury? The toxic stress from ACEs exposure can alter brain development, and it can lead to changes that look like brain injury, like impulsivity, poor judgment, and being quick to anger. And those risky behaviors can increase the chances of having a traumatic brain injury. If you live in a rural area, you're at a higher risk of sustaining a brain injury. If you're a member of a racial or ethnic minority, you're more likely to sustain a TBI and have worse outcomes. Over 1 in 50 Americans 75 or older experience a TBI-related emergency department visit, hospitalization, or death. Veterans with TBI have higher rates of PTSD, substance use disorder, and anxiety disorder. In the disability community, over 5 million have a long-term disability from brain injury. But most of these systems aren't looking for brain injuries. They see the behaviors and problems they cause, but they don't realize it's because of the brain injury. The person knows they're having difficulty, but they don't know why. They know they've hurt their head in the past, but they may have never heard it called a brain injury. It would be a game changer for both survivor and professional in any system working with them to identify the injury. First, screen everyone entering the system for a history of brain injury. Use a symptom questionnaire to screen for cognitive and functional changes. Educate staff, the person, and their families about brain injury. Give them simple accommodations like using a planner to keep track of appointments or setting reminders on their phone. Refer them to any community resources like symptom specialists they might need. And then monitor them over time and help them understand what types of things to look out for, like pain, changes in mental health, or trouble with the law. So where can you go for more brain injury resources? BrainLinks has infographics for people working in each system about how brain injury overlaps and what they need to know. Then, this main infographic brings the bigger picture of brain injury and all of those systems together. Online, check out these 4 toolkits for various professionals and for survivors. On the website, select Have an Injury for more information. Contact us at tbi@tndisability.org. Not from Tennessee? You'll still want to check out our website and definitely the Brain Injury Association of America and NASHA. Brain injuries everywhere. It's best to be ready. Be ready with BrainLinks and Tennessee Brighter Futures.
Awesome. And you might recognize that voice as Jennifer Raymond's. So that was a big overview of everything. We could probably stop right here and you have it all, but we'll go and reinforce some of those points. So hopefully you got an idea that it is bigger than you thought, unless you've heard us talk before. And we hear in many different systems, people saying to us, we haven't seen anybody with a brain injury. We don't have people with brain injury. Or yeah, we've had a couple. You've had, if you're in some of those different systems, you see that it might have been half of your people. And they have seen you. They're there. They are there. We just need to identify them to be able to help. We want to be helping them, but it is also going to help you. We're going to give you tools so it makes your job easier. And so why does it matter? Why do we need to bother to identify if someone's been injured or not? It's a very good question. Well, people with a brain injury are at a higher risk of a lot of things. They're at a higher risk of having another injury, of becoming obese, being incarcerated, abusing substances, becoming anxious, depressed, being socially isolated is one of the saddest ones. Lower educational attainment, learning disability, ADD, speech and language problems, bone, joint, and muscle problems. So there are a lot of things that we need to be looking out for these folks. And then there are common problems after TBI. So your brain, like I said earlier, does everything for you. So anything can change. And there are some pretty wild disorders out there that you can have after a brain injury, like alien hand and things like that. Just some really odd things because our brain does everything. But here's some really common ones that you might see. So physically, we might see balance and incoordination, vision difficulties, difficulty walking, movement disorders. That can also look like, so those physical things there can also look like someone is using substances. They may be, they may not be. And we don't always have the physical things, so there's not something physically that we can see or obvious that we can see. So they might have cognitive speech and language issues, slurring, forgetting words, slow to respond, difficulty understanding, over talking, under talking, problems with attention. That's going to be huge. That's going to be almost universal, problems with attention and decreased reasoning. Again, this list can go on. And then executive functioning is a subgroup of cognitive, and this is the frontal lobe functions, things like impulsivity, initiation, if that's starting something. Believe it or not, it doesn't seem like that would be hard, but for people, but sometimes it's difficulty for them to get started, to go ahead and do. Planning might be an issue, organization, judgment, self-monitoring, so a lack of awareness, flexibility. So the lack of awareness, sometimes you'll have people that are very aware of the changes, and sometimes you can have a very significant issue that the person has and they're not aware of it, or they're aware under some circumstances. They might say to you, oh, my memory's terrible, and then not do a darn thing about it because they're not aware that they're going to have that problem here in this situation. So as a clinician working in the hospital, sometimes that was the first thing that I needed to work on, because they weren't going to engage with me if I didn't help them to increase their awareness. And that needs to be done very I won't say just gently, because sometimes you can be over, but very supportive, in a very supportive situation setting and supportive language. Behaviorally, we might see things like impulsivity, aggressiveness, anger, rudeness, belligerence, being very loud, not knowing boundaries, whether they're like a verbal boundary or a social boundary or a physical boundary, maybe being overly emotional. So these are some of the things that you might see. You say, okay, but they were injured a long time ago, right? We used Nathan, who he was injured at 2 years old. Well, what this slide here says is that, and these are just two studies, there are a number of studies now that show that just because someone was injured young doesn't mean they're not going to have problems. In fact, we can look 10 years later and see that they have an increased likelihood of having things like ADD, conduct disorder, substance use, mood disorder, violence. So lots of different things show up 10 years later. And you say, well, okay, but how do we know that comes back to the brain injury? Well, sure, we don't know for sure, but we do know that in people with brain injury, these things happening is much higher than it is in a person without a brain injury. So we need to be thinking that the brain injury is probably contributing to this. And there are many more studies that show that just because they were injured long ago doesn't mean that they're going to be okay. When I came into this field many moons ago, there that was the conventional wisdom, was that I worked with adults. It was that children, they're not going to have a problem. Yeah, help them through that early part, but then the brain is so plastic, and a child's brain is so plastic that neuroplasticity is just going to heal everything, and that that is not proven to be the case. That children who are injured can have a much harder time, because as an adult, we already know certain things. We already have, I call them templates. Like, we have a template for how to behave in social situations and how to behave at work, and how this process goes, whereas children have to learn all of these things with an injured brain. So I think really children have the harder time. So what do we do? We need to screen for a prior history of brain injury. I'm going to help you with all of this. Assess, then, okay, we've screened, they say yes. We're going to screen then for cognitive or functional impairment, because just because you've had an injury doesn't mean you're having any problems from it. We're going to educate the staff. We're going to educate the person about their brain injury. We're going to provide and teach accommodations. And then we're going to connect those people, if needed, with community resources. But what we want to do is to get your system equipped to handle them, to not necessarily handle every question, or, we're here to support, but to be able to get you to the point where you can be supporting within your system. So why is that important? That is best practice. Why is that important? Well, our folks with brain injury are going to have a harder time using your services and then maintaining that change if they don't receive the needed accommodations. They may be back into your treatment again, or worse. We might not see them ever again if they overdose, or if they have a mental health problem and they harm themselves. So it's really important to be identifying them and getting them the support that they need. So let's take a look at James. James is 32 years old. He's in a substance use program. He says he wants to get clean, but he doesn't do it. He doesn't participate when he comes to group. He doesn't seem interested. And I'm kind of speaking there with a little frustration in my voice, because that's what it feels like. It's like, he says he wants to do this, but he just doesn't do it. He doesn't even participate. He doesn't even seem interested in what he's doing. This is his third time in treatment, which is now court ordered. He inconsistently shows up for appointments. Child welfare is involved, and he's in danger of losing visitation with his 4-year-old son. His employer wants to be supportive, but they're losing patients. And so for me, as a brain injury person, there are all kinds of red flags popping up when I hear this description of James. And you'll see that prior brain injury doesn't even come up for him. It's not on anybody's radar, including James. So this is the a way to screen. This is the OSU, the Ohio State Identification Method, but don't write that down. I'm going to show you the paper form. This has all been put into an electronic form, which is really easy to use. But what I want you to see from this is that there's not just one question. You can't just ask the question, hey, James, have you ever had a head injury? Or have you ever bumped your head? Because so much more goes into it. This has been modified to include all of those other types of brain injury that I mentioned at the beginning. So if we just looked at this is the TBI side pretty much, and we see that he's had 4 brain injuries from football. He has had some changes after them that suggest that they were at least a concussion. And we know, going back to that slide previously, that if he's been injured up to age 16, then he's more likely to have these other things happen, abuse substances, commit violent and property offenses. So we're kind of keeping all of this in the back of our head. And then when we look at this box down at the bottom left with other, it's all of those other acquired types of brain injuries. And what we see is that he had an overdose. So we know that for every, now this is data out of New Hampshire. I will say that we don't know if the numbers are this high. This is what they found in New Hampshire. We don't know good numbers. If you work in substance use, we don't know good numbers for every death. In fact, I'm going to show you that. But we know that that a number of people are going to have an anoxic injury from their overdose. And we know that just using drugs and or alcohol can produce a toxic brain. So you'll see as people clear, they'll say, oh, it's a week later. I feel so much better. It's 2 months later. Oh, I feel even more better. And it kind of keeps on getting better for a while as they are clearing. So we're going to assess for that next thing. So we've screened. Now we're going to say, okay, well, all right, so you had an injury. Are you having any problems? There is a questionnaire. There's the second part of this electronic screening it's called the SQUIBI, the Symptoms Questionnaire for Brain Injury. And from that comes a set of accommodations. So if I say, yes, I have a memory problem, both James and the clinician working with James are going to get a set of accommodations. And I'll show you more about that. So this is where they come from, the mind source, but it's now called the SQUIBI, this portion of it. And this is all the different things that it's asking you about. Do you have any problems in this? And specific questions. So you don't have to say, well, I don't know what delayed processing is. It'll ask you those questions. So those are all the different areas. And then, so this is the paper one. And we see from James acknowledged things like memory, forgetting meetings and appointments, delayed processing, taking too long to figure out what someone's trying to tell him. He's easily distracted, his attention, inhibition problems. He says things without thinking, language, difficulty finding the right word when he's speaking, and organization. And he didn't mention some other things. They were not issues. So for each one of these areas, James and his clinician received strategy. And they're going to look something like this. And so it's going to have, this is for memory, it's going to have this little section that tells you what this is about. And then it's going to give you some strategies. And on the next page, there are some more strategies. So it's a bunch of strategies that you can use, accommodations. I go back and forth between those two words. They mean the same thing. This will give you an idea of some different things that you can do that James can do to make things easier for him, to make it a better shot that he'll get through your program, and that he'll kind of be learning these things as well. Jen, you have a question?
I do. We have a question from an attendee, and I'm going to read it to you. I know a teen that fell as an infant and later was diagnosed with ADHD and processing disorder. The family has a history of being accident prone and ADHD, bipolar, and dyslexia. Should they follow up with their primary care doctor?
So I would say yes. It's never a bad thing. They may or may not know about brain injury. You might want to do that, and then go to the school system. And if this child is already receiving services, you might just want to let them know that there's a history of brain injury. And what they can do is also just look back at the time that it happened and kind of notice, did you see any changes? Now, it's really hard in a young child. You don't know who they were going to become, and that's why it gets lost all the time. You don't know that their behavior was going to be wonderful and their attention was going to be great. You don't know those things. So when they don't happen, we don't know that to go back to the brain injury. So, but I would go to the school and also get him identified there potentially. That might open up a new way of thinking for them. Now, a lot of folks in schools is not universal by any means, but school folks are becoming more and more aware of brain injury. and how to treat that. But for in the school system, it's all about these accommodations. We are trying to give the person a different way of doing something. So focusing on, say, using a strategy for reading comprehension, like our goal is underline keywords and write a brief summary afterwards to help with memory and attention, rather than just comprehension is going to be 80%. It's going to be 80% using these tools because that's what he needs. So hopefully that answers your question. Yeah, I'd go to the doctor, and maybe he'd get to the school, because if he's not receiving services already, he may be able to. It might be worth getting him evaluated. All right, thanks for that, Jen, and thanks for who asked that question. Good question. So here's some strategies. I'll talk a little bit more about that. So why I told you not to take notes on that earlier part is because all of this has been put into something called the OBIS, the Online Brain Injury Screening and Support System. If you do the OS, the screening part and the screening for problems, then it'll take max of about 24 minutes, but that can be a whole lot quicker. And you can take it. You can go to this site at NASHA and you can actually take it, or contact us and we'll help you to figure out how to do that. So just as an aside, I feel really strongly, we advocate that normally the way this might happen with the OBIS is that you screen for that prior history of brain injury. If it says, yeah, you've had this looks like you've had a brain injury, it's not a diagnosis, it's a screen. So it says, yeah, it looks like you've had one. You would then go on and complete the questionnaire to see if you're having any problems from it. If you screen, no, I haven't had a brain injury, you wouldn't go on. Makes sense, right? However, I would love to see, at least for a while, till we get more data, have everyone take this. Because if it says no, you haven't had a brain injury, yeah, but what if I had ACEs? If I had adverse childhood experiences, and so my brain has changed and I'm more impulsive, my attention is not great. Well, we'd still want to know that. Maybe you've had a learning disability. Maybe they were never told about their injury. We see that a lot, especially where there's maybe a parent or a family member that was a part of that injury, and they don't want, the person feels terrible and they don't want to bring it up. And maybe they don't want the child to know that this person was a part of you being injured. They don't get told, and maybe they forgot about it. That's why it's important with the screening to ask so many questions about it, because that'll help you jog your memory about, oh yeah. And I can't tell you how many times we'll hear things like, oh, do you mean that time that I was thrown out of a car? Yeah, we mean that. So we mean that. Things that would, definitely be on our radar are not on someone's radar who's gone on and lived past it. And then we might also spot a mild cognitive impairment, which may or may not go on to dementia. So we might see an early dementia. And these folks are not necessarily diagnosed. So they're beginning to have problems. They would never, let's say you work in an aging situation, and they would never say, hey, I've had I have dementia, because they don't. They haven't been diagnosed with anything. They just know they're having issues with their memory. Well, that would turn up here, and we can begin to spot some of these other people. You can say, okay, you haven't had a brain injury. You could dig deeper into that, or just start accommodating for the changes that they're talking to you about. So that would be where you would go. A next step, let's say that someone is really having challenges and they're so complex, you don't know what's going on. You can become trained. Jen and I are trained to be cognitive screeners. It's a 3-part course. It only costs $150. I would love to see, and then you'd have to buy the tests, the screeners. I would love to see a network across, at least across a system, like a mental health system that has screeners that they can go to, that they can refer someone to. So the gold standard for assessing cognition is a neuropsychologist. But we don't need to be referring everybody out to a neuropsychologist. This was developed by neuropsychologists and advocated for by neuropsychologists, so they're not looking for everybody to be referred to them either. So we can just do a cognitive screening, get a better idea of really what's going on in those areas. Or let's say I talked to you about awareness, that the person has zero awareness and it's clear to you that they're having problems in some of these areas. Then you can do a cognitive screening and get a better idea. And you could say, you know, it does look like you're having some issues in this, but it looks like you do well if you use this accommodation. So something to think about, something to look into. So I've been in brain injury my whole career, and I have seen a lot of stuff on brain injury. We've done a lot of our own stuff on brain injury, and this is a great course. It really is. So if you have the ability to take that, we would highly recommend it. So what's the impact on your program of having our folks there? Well, the cognitive and this is a little bit, I've said a little bit of this, the cognitive and behavioral changes are going to make it harder for them to participate in your program. The problems, cognitive problems, frustration problems, and they're going to have less ability to maintain that improvement if they don't have continued structure and support afterwards. So some things that we can do within our programs is speak more slowly, but be careful to not have condescension. I call it my therapy mode. I'm from New Jersey. I talk really quickly, but if I'm in my therapy mode, I slow down. I'm much more like this right now. I will pause for people to respond. I'm not trying to rush anything. Use simple, direct language. Keep calm and a low volume. That part is also really important for our people with ACEs, because if we clinicians, we tend to be like, that's great, you did awesome. Well, that can, if someone has trauma, that can kind of trigger them. So we just have to be careful of that. Give information in smaller chunks, repeat it as needed, pair talking with writing something down. I was always kind of, if I could work off of a form and be circling things and highlighting things, then I would be doing that, or a visual showing them how to do it as well. Some example accommodations, and again, remember that you will get accommodations from that screening. They'll automatically be sent to you. So some things though that are really we're not talking about this massive change to your program. You are probably already doing some of these things with folks because you're recognizing that they're having an issue. So you're automatically doing some of these things. We're kind of saying, well, let's take it a little bit further and know that they definitely apply to this person, and also that we can be applying them more universally within our program. So maybe writing things down on a whiteboard in group. Here's our agenda. Here's what we're working on right now. We've covered that. Let's write down a summary of what we just did. Any homework gets written down. Set up alarms for appointments. Ask the person, can you tell me what I said, or what did you take from that? Did I say that right? What did you hear? Supporting any efforts that they're already using to be organized, but maybe help them to now take it up a step, or just if it works well, as long as they use it, be reinforcing that they use it. Give them lots of education about brain injury and about their brain injury resources, and that will work for them. And I just want to say that when someone gets this, again, it's not a diagnosis, but they hear that they've had a brain injury, you might think that would be alarming, and maybe for some it is, but for a huge majority of people, it is a relief. It is, so you mean I'm not bad? So you mean I'm not stupid? It's like the reason for it just makes sense in their lives. So I would just encourage you to do screening, even just for that purpose. It can just, everything goes back and kind of fits into place a little bit better. So if judgment and impulsivity are issues, maybe plan ahead, anticipate triggers, think about consequences. Some other accommodations help them to be successful. So help them to understand their injury. What's a challenge? So this is building that awareness. if you can get them, I always loved it if during an intake, right, you're asking lots of questions. If they've told me something that they have difficulty with, that is amazing. Because I don't want to be the one to say, as a speech pathologist, someone over talking would be my job to say, hey, you talk a lot. Well, that's a horrible thing to say to somebody. We can't really say that. But if I can say, hey, you've said that sometimes you go on and on, those were your words. Do you think I can help you with that? Do you mind if I will come up with a sign and I can let you know when you're doing it? Is that something you want to work on? So you want to use what they've said whenever you can, and then just gentle cues you were saying to get them back on track. You know what? I think you took notes on that if they're having problems with memory and getting to reinforce that strategy. Hey, do you have any appointments tomorrow? Did you set your watch alarm for that meeting? And then giving positive feedback about how they're using the strategies. So in James's situation, he was involved with the recovery court. So some things that the recovery court could do is give everything in writing whenever that's possible. Also have it in writing. Give more processing time for responding to questions. In some people, this would be longer than you think it should be. Give a notepad to write down some things. Lawyers might summarize the proceedings at every break and at the end. You can't just, if a lawyer says to you, did you get that? It'll be like, oh, yeah, sure I did. They're not necessarily going to tell you the truth. They might not necessarily know. So it'd be to say, this is what just happened. Here's what's going to happen next. And then at the end, here's what happened. People can slow down when speaking, not just the lawyers, but anybody involved in that system. And then screening everybody and then implementing individualized strategies. They can wait while he puts his next appointment in his phone, cue him to do that if he needs to. Encourage him to stop and think before speaking. James can repeat back information. James can ask people to slow down, know that he might not. You can control the environment, getting rid of visual and verbal distractions. And then, of course, there are others that you could be using. Things in the substance use center. And I want you to, so that's what we've chosen because we're using James, but think about your setting and what would work there. Maybe you can have the person meet with someone, a clinician, for 5 minutes, a point person, could be anybody, 5 minutes each morning, just to make sure they know what they're doing, they know where their appointments are, they know what the day is gonna happen. You can reinforce, okay, write that down. Maybe I'll come back and we'll talk at the end of the day, or we'll follow up on this tomorrow. They can have a notebook that has different sections for different areas of their life, for treatment. For James, his son and child welfare court work. And then mindfulness and deep breathing are awesome, awesome tools because they change the brain. So we talked about that impulsivity, that lack of judgment, that high emotionality of frustration and anger. That all comes from the amygdala. And the mindfulness and deep breathing help to calm the amygdala so that the frontal lobe, which is responsible for all of that directing and organizing, so that the frontal lobe can actually think and do its job because it's not getting all this overload from the amygdala. So mindfulness and deep breathing are just awesome practices to teach everyone, really. It's just very, very healthy for your brain. And that's just a reminder about these strategies, the accommodations. So you can use the accommodations that come from the OBIS. You can also use these other ones. If you were in a school system, you might want to choose the one on the left. It's from the Center for Brain Injury Research and Training out of the University of Oregon. And it's got great, very school oriented. So when I would work with a student and their family, I would say, go through this and circle everything that you think would help. And then I'd say, okay, now go through it again and just give the most important ones, because the school is not going to remember to be implementing a ton, and neither is the student. So pick a manageable amount and get that written into the IEP. And then these are two other ones that we had developed for IDD that you're welcome to take a look at as well. So I just want to talk a little bit about giving feedback because it is an art form. It really is. And I was fortunate enough to learn, we worked on a team. So I was side by side with neuropsychologists and counselors and just people who, even in my own profession, who were much more my senior. And so you'll learn over time that there's just, and I already talked about some of this. So, I talk too much. That's a hard one to give feedback on, but no, that's great insight. Like I can help you with that. And they may not remember that. So they might say, you're being rude. And it gives me then the ability to say, you're right. That does sound really rude. You had said that it was okay if I give you some feedback when you talk too much, because this is something that you wanted to work on. If I'm not doing that in the right way, or if you don't want any feedback anymore, and I will tell you 99% of the time, I'll get, oh, no, it's fine. And I'll just make sure that I'm doing it in the same way. And then I might kind of remind them of that strategy a little bit more often. Still, okay, if I do that, right, we're going into this group. It's not going to be overt. It's not going to be a big deal. Teachers sometimes can just walk around and just tap on a note on the desk that says whatever the take notes, whatever the note is for that one. And so how about if I help you with these things? Refer out if needed, and that should be bold and just bouncing out. If needed, we want you to be accommodating within your program whenever possible. If necessary, absolutely refer out. We have awesome service coordinators across the state. There are 7 of them. But if you refer out everybody, they will get overwhelmed very quickly because they're already overloaded. But they can help you. You can even put a phone call out to them saying, hey, I need a specialist in vestibular treatment. Where do you know anybody near me? And they can help you with that. Or if someone is really complex or needs a lot of help filling out forms for something else, they can help with some of those things. A neuropsychologist can be appropriate for cognitive testing or that screening program that we talked about earlier down there. Cognitive rehabilitation program could be appropriate, and definitely a symptom-specific specialist. If they're having problems, if they're having eye issues, let's get them to a neuro-ophthalmologist. If they're having cognitive problems, maybe you refer out to a speech-language pathologist to help to develop some strategies. Balance, maybe PT. So just look at and I'll show you a tool that you can use to know who that should be. And then also our Tennessee Traumatic Brain Injury Program is a good place to look at. This is the document. So there's 2 of these for different age ranges. One is for the young children, 7 and under. There's another one for school-aged and adults. And what I like about this one is, first, if you are working in brain injury, you may want to give people this one, because this shows, hey, just because we're done here, we've discharged you from the hospital, doesn't mean that you or your child may not have problems. So we just want to give you, and they may be fine, right? We don't want to worry anybody, but they might be fine, but we want to give you some things to be looking out for. And so on the blow up box there, it's inside this document, shows here are the problems that you might be having, and here's who to go to. So that can be a great thing right there. And this is the one for adults and school age. So we have lots of resources to help educate your folks. You can reach out to us. You can go to our website, tndisability.org/brain. That's the BrainLinks website. And then a sub part of that is for Tennessee Brighter Futures, which is a collaborative that we ran for 3 years that pulled together all of the different systems to educate them on each other. Because if I know that my people with brain injury are in all of the different systems, so in order for them to be have their needs best met, I need all of those systems, not just to know about brain injury, but to also know something about some of these other systems as well, so that they know how to refer to those systems. So you can look at the Tennessee Brighter Futures information. So something that you might find on our website are the signs and symptoms tools. This is all different age ranges. And then this purpley one is for people who communicate without words. And that is, this is good if, like, who did we talk about? Okay, it was the question that got asked about a student who had been injured earlier. You might show them a parent, one of these, this is for the train is the very, very young. And then this one with the little girl and the little boy on it is for more like school age. But you might say, hey, do you recall them having any of these symptoms at that time? That would at least give you a sense that there might have been a concussion at that point. And then if someone just gets injured right now in your program and they come into you and say, oh, I fell yesterday and hit my head, first you're going to want to refer them out. You might have a protocol in place where you need to do that, but then also you can have them take a look at this and see if they're having any problems. And their danger signs are on those as well. When you absolutely need to get someone to the hospital. And these might have been good for Aaliyah to say, did you have any of these symptoms at the time? There are also resource pages by each topic. So this one is on criminal justice that gives an overview of the criminal justice system, the intersectionality with brain injury, and then key resources for that system that go along with that system. And so the people in criminal justice may not need this. This is more for the people who might be referring into a system to help them know about that system better. These are infographics. We also have these for each system. This is brain injury and chronic pain, and this is just a front and the back. And we have one for each. There are about 16 of them, I believe. And they give that little box there at the top of each one is how brain injury intersects with that system. And then you'll see that the next three circles, they're the same for everyone. There's little tweaks that fit that system best, but this best practice that we've already gone over that you would recognize, screen, assess, educate, provide resource, accommodations, connect, is the same for each system. Maybe tweaks. And so for James, these might be the things that we might pull out for him. We might, if we're in a, let's say the recovery court, we may need the other ones, and we can give them to the other places that they're working with, so that, let's say the substance use facility isn't screening for brain injury, but they understand that this goes along with the injury that James had. So here's some information about that and kind of increase awareness. These are also great. So James might be good for it. They're also good. Do I have a little? No, not on that one. They're also good, these infographics for taking to administration to say, I think this is something we need to look at, is to screen for brain injury. This infographic pulls together all of the different areas and just gives you a snapshot of how brain injury intersects or overlaps with each one of these areas. And it would be interesting, just as an aside, think about what if your system was in the middle? What connections do you have to all of these different areas? Because you probably have a bunch. And then on the next page at the top, we tried to give the numbers of brain injury. There are not good numbers in the field at this point. The best numbers we can come up with is about 64 million people in the United States right now are living with a brain injury, but that's a traumatic brain injury only, and we know that is not all of the different types. We know that's not anoxic injuries and early dementia, which some people wouldn't include anyway. It's not strokes, it's not tumors. So if we begin to include all of those things, the number is much, much higher. And then, of course, I rarely talk about brain injury without also including ACEs as just an educational piece of that, because those folks are going to have issues with enough ACEs. It changes your brain, and they're going to have issues that can look very much like a brain injury. Okay, so they're not a brain injury. So why do I need to know that? But they can be, the same strategies are going to help. And if you're working in an intellectual and developmental disability field, then the strategies are still going to help, even though we may not call it a brain injury. So on the next pages, it just gives, you might recognize, these are condensed, but you might recognize these ovals as being they're lifted from those other individual infographics. So here it is all in one infographic. And then those same 3 circles of best practice, it's the same. Again, we're going to tweak, and I think right now domestic violence is probably the one we might tweak the most. But again, the general steps are still going to be the same. Common problems are there, what to look for, some accommodations just to get you started, and some tools and websites. We also
Wendy?
have, yes.
Excuse me, this is Paula. I'm sorry. I just wanted to chime in and let you know we've been putting some of the links in the chat. I've just put a link to the complete infographic series in one PDF, so it's an easy download. Thank you.
Thank you, Paula. Thank you. And they may also be putting the toolkit link in there next. We have 4 toolkits. We have one for survivors, families, and caregivers. And this one might be one that you might give the whole thing electronically to a family, or you might pull out what you think they need. This is admittedly way too long. It has too much good information in it. That's because we never know when people are going to get to it. We don't know if they're going to get to it immediately, and they just need these basic facts, basic signs and symptoms, and fact sheets, or are they going to get to us later when some of these other issues are starting to come into play and they need help there? So you might just want to pick and choose what people can that you're giving people. That there's a family caregiver resource section as well. The second one is the service professionals toolkit. That would be for all of you. So this is a little more focused on what you would need, including some continuing education that you can get. And then there is a healthcare providers toolkit and a school nurses toolkit for them specifically. Another important resource might be when concussion symptoms aren't going away. We get a lot of phone calls with this, where I had a concussion and I'm having problems and I can't work and it's been 3 years and everybody's, the doctors, everybody just wants them to move on because it was only a concussion, but it can have a big result. So this is a good thing to give people when their concussion symptoms aren't going away. It's also a good thing to give people when they have a concussion, because they may not come back to you, because we still have the belief in this country that there is not a lot that you can do for a concussion, when there is a lot of evidence-based treatment for concussion. And that's what's happening with all of the elite athletes. When they pull the NFL players into that concussion tent, they get assessed, and they are very quickly put into treatment rehab for their specific symptoms. They're going to target those. This is also a good resource if you want to read a little bit more. This is in the behavioral health area. This is a good tool. I'll just explain it all to you. And that's good for like the people working with James and also with Nathan and with JJ. With aging, there is a specific guide on aging and brain injury. I know we have some people who work in that space on here today, and also our parents, helping them age. Domestic violence has its own some of its own sets of things, and so this can be for someone like Aaliyah. And why I have that. The middle one is more for clinicians. So we have our clinician there, but the two on the right hand, on either end, are things that you can give, and they can help to normalize the experience, to say, oh, like my symptoms are common enough that people were able to write them down, which it can be really helpful. I'm not alone. They do know what I'm going through to some degree. In the child welfare space, this is a guide. I'm one of the co-chairs of this group that put together this guide for bringing brain injury into a child welfare system. This is a best practice guide. And again, this is more for clinicians. And you do have access to this slide deck. I'm going to show you a QR code if you weren't here at the very, very beginning, where you can get the slide deck and you can see some of these things more at your leisure. And this might also be good for the people who are working with James and his son in child welfare. In the justice space, there are also some very good tools. There is in our field, there tend to be like a lot of guides for each specific one. So it's good to go and read yours, but know that it's going to say largely the same. Like if you don't see your area represented, you can almost go into one of these and substitute out. It's going to give some specifics about that system that won't relate to you. You know, like how does the justice system work? But you can go, okay, here's what I need to do. But really, it's as simple as what I'm telling you today, that using the OBIS is going to give you all of those pieces there. So this would be good for James as well. And this one is also on substance use, justice system. There's a national database that you can go in and you can search. Maybe you want to know more about crisis intervention training. You can go in and you can search that. It's a great thing out of North Carolina, and I know North Carolina is represented here today. There's a great fact sheet on brain injury and opioid use. Great, love this one from North Carolina on the right-hand side on crisis management and de-escalation. Great for law enforcement and other first responders. Give you an idea of what to be looking for. In the mental health, so no matter what area you're in, you may need these on mental health and brain injury. And then some trainings that are available. So we have a bunch of trainings on our YouTube training channel. You can go and see a variety of playlists that we've created, different trainings that we've done along the way. And then on February 26th is the second part of this training series for this year, is on brain health. And that is for everyone. So it's going to help you with your clients, with the people that you serve, but it's also going to help you with yourself and with your family. There are lots of great tips and things to be thinking about. And I think when you're working with people with brain injury, if you look at some of the literature, you often see a decline in our folks. And I'm incredibly, like, if you hear anything, I always tell people, especially with the brain health one, if you hear anything that's upsetting you, tell me that, because there's always an upside. And I don't think that this decline has to happen, especially not with mild and moderate. I think it's regarding choices sometimes that we make, and that if you've had a brain injury, remember I said that you're more likely to become obese if you've had a brain injury. No, that's an American problem, period. But it's worse for people with brain injury because they don't always make the right choices. So if you can help them to be educated and make some of the right choices, then about all aspects of their life, then that can be really helpful. So that's there as well. And I want to say this is really important to me, that brain injuries, even though I'm an advocate for people with brain injuries are reasons. They're not an excuse. So just because you have a brain injury does not make it okay to go and do X, Y, and Z. You know, if it's illegal, it's illegal. If it's not right, it's not right. It's the reason why you're doing it, but it's not an excuse. So having a brain injury, I think there's a laudable kind of movement in our country right now to kind of say, oh yes, but this has been their situation. Well, as a brain injury expert, people with ACEs and people with brain injuries are not getting the rules in their head. They're not getting that stop that the rest of us get. So they need rules, boundaries, requirements, expectations, consequences, accommodations, even more than other people, because they're not getting it from their head. They're not getting it. So I use the example, like for me to break the law, it would take a lot. That I would have to be pushed to some extreme. I don't know what that would be, but I'd have to be pushed to an extreme, and that would hold for a lot of you here. With a person with a brain injury, it's easier for them to cross that line because they're not necessarily thinking of the big picture, or they're impulsive. Their anger gets a hold of them, and they do something that they shouldn't, and it may regret. But so we've got to be giving that structure, the boundary, the requirements, all of that outside. Outside has to come from the outside. Hopefully that makes sense. And so just a reminder, what we're asking you to do is a simple process, because most of it is just going to come right through the OBIS, the online brain injury screening and support system. So we're asking you to screen for a prior history of brain injury, and then do a screening, that's screening would be a better word, for cognitive and functional impairment, educate your staff on brain injury, educate the person about their brain injury, provide and teach accommodations, which are going to be right there. They're going to be handed to you from the SWIBI part of the OBIS, the screening, the question part of the OBIS, and then connect them to community resources if needed, if and only if needed. What I wanted to say about this is that I don't know if there's anybody on here from Cumberland Heights, but we're working with Cumberland Heights using this protocol there. And whether you're from Cumberland or not, the kind of the reaction we get is like everybody, all of us are so overworked, right? We're doing a lot of really great work. And the thought of doing one more thing can be overwhelming. And so that initial reaction is, oh no, not another thing. What has happened, it appears from our vantage point, is that they have taken this in stride. They've realized that we're not also asking you to treat a brain injury. We're asking you to do what you do, but pull in these strategies. And these strategies are going to make it easier for you to work with that person and more effective. We're just giving you one more tool for your toolbox. We're not giving you a whole other toolbox. It's like, here, just put this in there too. And what we're finding, we had thought that what we would need is maybe a monthly call for them to ask us their questions. These are seasoned clinicians. They're awesome clinicians who are taking this in stride, and they're like, okay, got it. I just needed that paradigm shift in my brain to say, this is a brain injury. This is what I see with a brain injury. You've given me the tools. I'm good to go. So that might not be for everybody. We might do that at some point as we expand use of the OBIS. But I wanted you to at least hear that experience, that at least there are people on staff who can go, okay, here's what we're going to do, and help the other folks, and don't need us, but we are here.